¿Qué tal? Bienvenidos a esta sesión de desafíos en cirugía por parte de la Sociedad Panamericana de Trauma. El de la voz, el doctor Felipe Vega Rivera, presidente actual de la Sociedad Panamericana de Trauma, le da la bienvenida a esta sesión que estará moderada por la doctora Tanya Zakrison y con los casos clínicos que el doctor José Julian Serna expondrá, con los comentarios del doctor Demetrio Demetriades, doctor Sandro Rizoli, doctor Santin, el doctor Fernando Hernández y el doctor Hugo Gómez. Doctor José Julian Serna, le doy la palabra, adelante.
Bueno, bienvenidos todos a esta actividad. Vamos a hablar hoy de carótida. Vamos a empezar con el primer caso. Este es un hombre de 35 años que se presenta al servicio de urgencias porque presentó una herida por arma cortopunzante en la cara izquierda del cuello. La herida fue hace aproximadamente 5 horas. El paciente es admitido al servicio de urgencias con unos signos vitales bastante normales y llamaba mucho la atención que a la evaluación inicial del paciente, el paciente tenía una hemiplegia del lado derecho. Entonces, la primera pregunta es si alguno consideran que este paciente, con esa presentación clínica que él tiene ahí, requiere la realización de algunos exámenes diagnósticos.
Why don't we start with Dr. Demetriades?
Yes, it's 5 hours after the injury, and he has hemiplegia. It means that there is a thrombosis or transection of the carotid on the left side. I would do, if there is no delay, I would do a CT angio for 2 reasons. Number one, I want to see the collateral circulation of the brain, but most importantly, I want to see if there is an established anemic infarction of the brain. If there is anemic infarction of the brain, then there's no point of doing revascularization. If it doesn't show any anemic infarction, I will go ahead and do revascularization.
So I think in my view is that anyone with any injury, penetrating injury to the neck, who has any neurological finding is a hard sign. This patient must be investigated if the patient is stable, as this patient seems to be. So I would probably do also a better physical examination, maybe sometimes hemiplegia plus associated with proprioception or loss of pain on the other side. Could be some weird syndromes that we see sometimes, like Brown-Séquard. But I think that the answer is only one. This patient must go for a CT scan if he is hemodynamically stable.
I agree with what Dr. Demetriades and Rizoli said. Maybe, and sometimes due to the time that to transport to the CT scan, maybe we can do an ultrasound Doppler to see the specific place where the carotid is thrombosis. But
yeah, I think that's this is Dimitri again. I think that's a very good point. But the main key point, the message, if there is anemic infarction and you do revascularization, you convert the anemic infarction into the hemorrhagic infarction, which might make things worse. 5 hours is borderline, so I will be a little bit more liberal towards revascularization if I do not have CT scan immediately available.
We used to do a CT scan because he's stable. The only neurological finding was hemiplegia.
So if the hemiplegia is on the right side, then it's not a Brown-Séquard syndrome.
Yeah, that's right.
Because the Brown-Séquard is ipsilateral spastic paralysis, so it has to be carotid.
The only finding was hemiplegia.
On the right side, on the opposite side.
Contralateral.
Yeah, yeah.
Okay. It has to be carotid.
Any answer?
In my mind, I'm suspicious about a common carotid laceration leading to hemiplegia because it's 5 hours old and you would have an exceptional amount of blood loss, and I do not see a lot of blood loss. So I'm a little suspicious that there's something odd going on here.
That's a good point, Tanya, but I can tell you, last night I was on call and I had a person with an iron stuck into his buttock up into the groin with thrombosis of the femoral artery, zero hematoma, zero nothing. So you are right, but sometimes it happens.
We take the patient to surgery, fue llevado a una cervicotomía, pensando que habíamos encontrado un signo duro de lesión vascular, la hemiplegia contralateral, y como el paciente llevaba 5 horas de la lesión, decidieron el grupo que lo estaba manejando llevarlo a cirugía y encontraron una lesión en la arteria carótida común, como la ven en la imagen, con adecuado flujo proximal y adecuado reflujo distal. Este fue el hallazgo intraoperatorio y la siguiente pregunta que les tengo es ¿cuál creen que es el mejor manejo para esta lesión ya estando en cirugía? ¿Revascularizar o ligar la arteria teniendo en cuenta las condiciones del paciente en este momento, que lleva más o menos unas 5 horas de la lesión y que no tenemos una escanografía?
Dr. Santin, what do you think? What would you do?
Well, I think the patient is stable. Maybe you should try the repair.
Google.
Yes, I have a question before that. How many hours after the injury took you that patient to the operating room? Because you said 5 hours after injury he was admitted, but how long it took to go to the operating room?
5.5 or 6 hours.
Yeah, so your case is really tricky because we are within these 4 to 6 hours that we are allowed to make the revascularization. But since you don't have a CT scan, I'm really concerned about make a revascularization. Since you have a very good backflow from the external carotid artery that might give flow to the distal carotid part. So I will probably give the chance to maintain that patient alive and ligate the carotid artery.
Dr. Rizoli, do you agree?
Yeah, this is the challenge of not having the CT scan, right? So at this time, you're at the edge. It may be too late. You may still have time. It would be good to know if he has already an infarct of his brain or not. And usually my inclination in case like this would be to revascularize, in fact, to repair and revascularize, despite the risk that I may be converting a ischemic stroke into a hemorrhagic stroke. There's also the ideas of you checking the retrograde flow, the retrograde pressure, and so on. I find that they most of the times are not used when the decisions are made on more crude information that we have.
Thank you. And of course, Dr. Demetriades, this goes back to your original point. What do you recommend? What would you do with this situation?
Yeah, I think I agree with Dr. Rizoli. I would do revascularization, having in mind that the blood flow it could be due to from the external carotid. The internal carotid might be thrombosed, and the blood flow is from the external carotid. But I take the chance if the patient has reversible hemiplegia, the revascularization will give the best chance. The worst scenario, the patient will die, will be converted to a hemorrhagic infarction. But they'll go ahead and repair it.
Okay. Excellent. Dr. Serna, should we continue?
Por la última pregunta que les tengo para que discutamos un poco respecto al tiempo. ¿Cuál creen ustedes que sería un tiempo? Porque el reto de este caso es que no tenemos una escanografía y lo llevamos a cirugía y nos encontramos con la lesión. ¿Cuál creen ustedes que es el tiempo adecuado para decir, hombre, yo sí voy a revascularizar a este paciente con esta lesión de carótida?
In English, so again, the last question as written is, do you believe that the time of injury evolution might determine the making clinical decisions over this patient? So precisely, what is that importance of time? What isn't that importance of the window of which you speak? And just Dr. Serna was mentioning this will be the last question for this case. Is that's correct, Dr. Serna?
Yeah.
Okay. Why don't we start this time with Dr. Rizoli? What do you think?
Okay. So time is important. Basically, everything we do in trauma is time related, time dependent. So the faster you do anything, usually the better results you get, and that's how it goes with brain. So time is brain. But certain things are changed, right? A lot of our decisions now are based on CT scan results, on imaging, because we realize our limitations as clinician to determine the exactly status of the brain or some other organs. I would say that 5 hours is already gone beyond the ideal. Ideal would be around 4 hours maximum, but if you can operate in the first hour, your chances are much better. Probably a better determinant here of what to do would be the CT scan and whether you have already evidence of ischemic brain insult or not.
Excellent, thank you. And Dr. Demetriades, why this talk of CT scan with a hard sign of vascular injury? Why is it important to see if there is an ischemic insult or no? With revascularization. Maybe you might explain for the
if
audience.
the patient comes very early, I do not need a CT scan. I will go straight to the operating room. But as Dr. Rizoli mentioned, the time is absolutely critical. And the 4 or 5 hours is just in the gray area. And if you have an anemic infarct, an established anemic infarct, and you do revascularization, is going to convert to an hemorrhagic infarction, which has a significantly worse prognosis. Having said that, you need to have in mind that in the first 4 hours, only 50% of patients with an anemic infarction, early anemic infarction, will show on the CT scan. Mm-hmm. It's too early, and very often the CT scan will show normal, but there is an anemic infarction. And for each case, we need to individualize. Some patients have a little bit of collateral circulation from the opposite carotid. Some do not have a very well developed Willis circle. So we play case by case. If the patient comes 10 hours later, 12 hours later, there's no doubt I'll leave him alone. But at this area, at this time, 4 or 5 hours, it's tough. But I would go ahead and vascularize.
Dr. Gomez, do you agree with that in terms of, let's say this patient did come at hour 10 or something, or is that hour framework very important for you as well?
Yes.
Do you agree with that?
Sure, I agree completely. The more prolonged time before I revascularize that patient is more dangerous for the patient. And I will use that frame time like 4 or 5 hours. And that's why in this patient, he was going to the operating room 5.5 hours. So it's a little bit going to the other side. And also something that I will add is that in that case, if I decide to make revascularization of the carotid artery, I have to put a intracranial monitor to monitor the cerebral pressure. So it's very, very difficult to handle a hemorrhagic situation after revascularization, and also the brain edema that will require decompressive craniotomy. So that's why I will not do the revascularization in this case.
Thank you. And Dr. Santin, it's an interesting discussion. Ligate, accept the hemiplegia, try to revascularize with risk of hemorrhagic stroke and maybe even death. What are your thoughts on that?
Yes, it's a great discussion about that, but if you have images that demonstrate other injuries or anything about the brain, I think it's important to think a gate could be possible, as Dr. Gomez said. But when you do palliative care, sometimes you need to do a lot of things, and these discussions, it will be after the decision, not in the operating room. If you ligate and leave him only with the hemiplegia, it's one situation. But if you have a damage in the brain worse than they have before, could be a problem after that. So, but I think if it was me that I was attending this case, I would do a CT scan, and then if I decide to go to the operating room, I will try to connect, not like it.
Thank you. And Dr. Vega, any final comments to this excellent case?
If any one of you in the revascularization option can think that to do it an angio in the OR to see what happened in the brain and the collateral system, is that a good idea? What is your opinion?
Who would like to answer that?
Yeah, I can answer that. I wouldn't do that. A very easy way to see if there is collateral circulation is occlude the backflow, occlude the external carotid. And if there is still backflow, it's from the internal carotid. It's very easy and very quick to see if there is collateral.
I have a comment. I remember one case in particular where we had a patient who was working on a chainsaw, and the chainsaw hit his neck. So he came in, evidence of a vascular injury. We took him to the OR. I remember the vascular surgeon scrubbed with me, and for many reasons, we decided to ligate this carotid. And this patient had a massive hemispheric ischemic infarct following the ligation of the artery. So, and the patient ended up dying. So I think that often with carotids, the right answer, especially the earlier it is always try to revascularize it, unless you have evidence that you have a installed infarct already in the patient.
Yeah.
Dr. Rizoli, I was going to add to that. Actually, back in Toronto at St. Michael's Hospital, I remember we had a waitress who was carrying soup at her restaurant. She spilled some of the soup right after New Year's. The chef got angry at her, took a meat cleaver to her neck. She ran out of the restaurant, but then collapsed and arrested on the street. Brought her in. We did an ED thoracotomy on her, actually, got her back. Same thing, ended up ligating the carotid after intubating through the hole in her neck. And sadly, same thing, and she was like 40 years old or so. Sadly, bad ischemic infarct, elevated ICPs, and she ended up dying too, which is a very somber way to end this excellent case. Thank you so much to the panelists and Dr. Serna. Let's carry on to the next one. Thank you.
Can I ask what happened to the patient?
Este paciente, el grupo que lo manejó lo revascularizó. Se hizo una revascularización teniendo en cuenta lo que discutimos, se tenía 5 horas y medio, 6 del trauma, y el paciente hizo un edema cerebral de reperfusión, fue llevado a una craneotomía descompresiva, unidad de cuidado intensivo, y el paciente finalmente se recuperó, pero estuvo como un mes hospitalizado y salió con bastantes secuelas neurológicas, básicamente hemiplegia del lado derecho. Creo yo, mirándolo retrospectivamente, que de pronto haber ligado la arteria hubiera sido la mejor decisión con él.
So it's very interesting. They brought the patient to the operating room, they revascularized, but the patient ended up actually having a hemorrhagic conversion of their ischemic stroke, and if I understand clearly, underwent actually a decompressive craniectomy as well, but remained hemiplegic, survived, but remained hemiplegic, and so Dr. Serna is saying maybe the best thing would have been simply to have ligated. But I know Dr. Serna has some other comments now.
Es muy importante que sepamos que mucha gente trabaja en lugares o atiende pacientes de trauma en lugares donde no cuentan con escanografía ni con arteriografía en su hospital, y muchas veces llevan a los pacientes a cirugía sin contar con este tipo de ayudas diagnósticas. Por eso me parece muy importante concluir varias cosas. La primera es que el tiempo sí es importante, como decía el doctor Demetriades y como lo ha publicado el doctor Demetriades, muchísimos años atrás, posiblemente los pacientes de menos de 4 horas con estos signos de lesión vascular, lo más seguro es revascularizarlos. Existe una zona liso de penumbra que es entre las 4 y las 6 horas, donde es muy difícil saber sin una tomografía qué hacer. Y en los pacientes que llevan más de 6 horas, seguramente la mejor estrategia con un caso de estos es ligar la arteria. Siempre que se cuente con una escanografía es mejor entrar a cirugía después de tener una escanografía para evaluar el estado neurológico, las arterias colaterales que hayan o la circulación colateral y evaluar el estado neurológico y el cerebro si tiene ya signos de isquemia instaurados. Creo yo que es un caso que enseña mucho y les agradezco mucho por todos sus comentarios y la respuesta.
Final comments, again, to reiterate what all the panelists are saying, Dr. Serna summarized that beautifully, is again keeping in mind, especially with the people that will be watching this webinar, is not everyone has access to CT scans or angiography, etc. But again, with the less than 4 hours, it sounds like we agree all as you know, as panelists, you were all mentioning that you look for the hard signs of penetrating neck trauma. And if it's vascular, again, within the 4 hours, revascularization would be recommended. 4 to 6 hours is that gray area where, you know, what to do. It'd be great if you had a CT scan or so. And certainly after the 6 hours, ligating would be ideal, is probably the most ideal, and especially if you can get a CT scan indeed at that time. But thank you. Gracias, Dr. Serna.
Gracias, Tanya.
Very nice case.
Vamos al segundo caso. Este es una mujer de 22 años que se presenta al servicio de emergencias porque sufrió una herida por arma de fuego en el hombro izquierdo hace 1 hora. Los signos vitales con los que ella llegó al servicio de urgencias son estos que ven ahí: una frecuencia cardíaca de 80 y una presión arterial de 110/70. Al examen físico se veía muy bien, sin ninguna alteración, solamente el hematoma que ustedes pueden ver ahí en la imagen, en la diapositiva, y el orificio de ingreso es en el hombro izquierdo, pero no tiene ningún orificio de salida, y su examen neurológico es completamente normal. Fue llevada a una escanografía donde se evidenció lo que vemos ahí, una lesión completa de la arteria carótida común, inmediatamente por debajo de la bifurcación. La paciente pues está neurológicamente normal. La primera pregunta es, ¿cuál creen que es el mejor manejo para esta herida? Ya viendo la escanografía. Y complemento ahí, si ustedes creen que es para llevarla a cirugía, ¿cuál creen que sea la mejor forma de manejarla?
Doctor Hernández, ¿qué opina usted?
Observando ya una vez el estudio de la tomografía, pues no hay duda que esta paciente amerita un tratamiento quirúrgico. Si a esto se agregan que tenía el hematoma y que muy seguramente un hematoma pulsátil y que seguramente en esa hora que ya había pasado desde el momento de la lesión al momento que llega al servicio de urgencia, pues seguramente también era un hematoma en expansión, por lo que el tratamiento que yo recomendaría y que probablemente le haríamos en mi institución es la exploración quirúrgica, la exploración cervical, una herida en collar, por la posibilidad de expandirse hacia el lado contralateral de la lesión. Una vez estando con la lesión in situ y observar la hemorragia, probablemente realizar, si se empieza a hipotensar o empieza a tener datos de choque esta paciente, probablemente colocar un shunt, si es que no tenemos la experiencia para realizar algún tratamiento vascular, colocar el shunt y mantener el flujo, estabilizar, pasar a la unidad de terapia intensiva a la paciente, y una vez ya normalizados sus constantes vitales, solicitar probablemente la valoración con un vascular para llevar a cabo la intervención o el STAR 2, la exploración quirúrgica nuevamente, y dar el tratamiento adecuado a la lesión en ese momento.
So, and basically Dr. Hernandez is saying probably bring him, because of, by virtue of having an expanding neck hematoma, that would be, you know, mandated to bring to the operating room. Obviously you have the imaging as well. And so they would explore that. And it depends really on the hemodynamic status of the patient, if the patient's in shock or not, and whether you're going to do damage control vascular surgery. And in that case, that would be something like approaching the carotid artery, with a shunt. You can position a shunt inside the artery, and then the patient can be returned to the ICU, and you can resuscitate them there at that point. And if I understood correctly also, and then once they are stabilized, you can bring them back to the operating room, and plus you can have the support of vascular surgery with you at that time. Yeah.
Can I make a comment, Tanya?
Absolutely.
You know, in hemodynamically unstable patients with vascular trauma, shunt is the way to go, damage control. However, in the patient with a carotid injury, we need to be extra careful. If you do an iliac artery shunt and something goes wrong, it's not a disaster. But if you have a shunt in the carotid and something goes wrong, gets thrombosed, it's a total disaster. So I will try very, very hard to do reconstruction at the first operation, unless the patient is really about to die. I want to emphasize this. Be very careful with damage control shunts in the carotids.
Dr. Santin, what do you think? Do you agree? Would there be a role for damage control surgery? How would you approach this injury?
I think we need to take the patient to the OR, and the best option is try to do primary repair. If you could do that, because the patient is stable, you don't have an option. And maybe here in Brazil, we have a lot of hospitals that we don't have vascular surgeon and neither trauma surgeon. And I think in this case, maybe you can shunt too. I think the best option is primary repair.
Okay, excellent. And Dr. Rizoli, do you agree with your colleague from Brazil?
Yeah, I agree completely, and I found very interesting also Dr. Demetriades' comment about shunting the carotids. I'll pay attention to that. The other thing I just noticed on this case is the hematoma seems to be at the base of the neck. So this is the patient that when I would take to the operating room, I would make sure that I would have access to the chest as well too, in case I need it. Like I know where the injury is now with the CT angiogram, but the location of the hematoma indicates that something in the chest could be present as well. Very interesting case, and that would be my choice as well too. It would be surgery. Yeah.
Okay. Okay. So surgical repair plus or minus median sternotomy, would you say, for access to your chest, or how would you do that?
If necessary, yes.
So prepping just in case you need to do that.
That's exactly. Yep.
Okay. And Dr. Gomez Fernandez, what would you say? What do you think about surgical approach?
I think that this is the ideal patient, stable, 1 hour of injury, penetrating injury, zone 2. The best approach is go directly, proximal and distal control, and repair.
Excellent. And what would you use to repair it with? Primary repair? Would you use graft? Or I'll defer. Dr. Serna might have something to comment on that. Doctor Ordóñez, si usted quiere comentar un poco sobre el caso.
Es muy interesante. Esto es una herida por arma de fuego en toda la bifurcación de la carótida, antecito de la bifurcación, con un hematoma, pero estable, y la paciente perfectamente, neurológicamente muy bien, y el hematoma no es expansivo. Entonces la pregunta es si realmente una paciente de estas necesita ser operada como siempre lo hemos hecho, llevarla a cirugía, hacerle cervicotomía y hacerle una resección y un injerto de góretes, o realmente podrían pensar en no operarla o hacer un manejo endovascular.
Dr. Demetriades, we were talking with Dr. Or wondering, do you come to the operating room, do the standard, operative surgical repair, risk ischemic injury or anything like that? Or is there any role for endovascular repair? Is there any role for conservative management? Do you need to always approach these in the same open, aggressive kind of surgical approaches in this completely hemodynamically normal, neurologically intact patient? Dr. Demetriades, what would you say?
I think that's a very good point. very often in penetrating trauma, it's a big injury. It's a transection and the patient is bleeding and you need to go in. But in some cases with with an aneurysm or an intimal tear, you might try to go with endovascular by standing. It's rarely in penetrating trauma. Blood trauma is more common that the patient will be amenable for standing. But it's an option you might consider in carefully selected cases.
I agree with Dr. Demetriades that this is not the place for endovascular treatment, but also I learned by Dr. Demetriades that a CT scan can give us the trajectory of the missile along from the entrance where the missile is. We can maybe think if the bullet is close to the artery and if we don't see bleeding, flushing of the contrast, it can be a blunt trauma of the surrounding tissue and can thrombose the carotid artery. I will use that only in centers where I can have everything 24 hours. In the hospital where I'm working, I don't have that possibility. I will go straight to the operating room to make the repair.
Tanya, if I may add, it depends also very much on the anatomical side of the injury. If the injury is in an easy way, surgically it's very easy to find, like in the common carotid, I'll be very straightforward for an operation. But if the injury is quite high in the internal carotid, where the surgical exposure can be challenging, I will be more liberal considering an endovascular stent.
That makes perfect sense. Dr. Hernandez, I think you had a comment.
Yes, I agree that the endovascular treatment is the best, but in my country, in my city, maybe the possibility to have the endovascular treatment is very difficult. The better treatment is the surgical treatment by a general surgeon. I agree that the endovascular, but the difficult to have either person or the either surgeon is very difficult in my institution.
Dr. Vega?
It's quite the reasons in most of the parts of Mexico City don't have endovascular therapy. And maybe some institutes, large institutes, have the endovascular therapy available all the time, but most of them don't have it. So I think it has to be a necessity in the hospital that receive trauma the most of the time. It's difficult sometimes. I think this type of injury, I will go for it just in some cases if the injury is too high and the challenge of the approach, I think is the endovascular therapy can be useful.
Tania, mira, para nosotros es muy importante esta discusión que estamos teniendo ahora. Pensar que todos los pacientes con trauma de carótida penetrante deben ser llevados a cirugía, digamos que es un concepto que nosotros hemos ido replanteando los últimos años. Y si vemos esta paciente en particular, es una paciente que está hemodinámicamente estable y que neurológicamente está intacta. A los pacientes hay que involucrarlos dentro de su tratamiento y cuando uno le pregunta a un paciente si quiere ser llevado a cirugía con los riesgos que tiene la cirugía de carótida, estando neurológicamente intacta, creo que los pacientes también hay que involucrarlos en esto. Este fue el caso de nosotros acá y decidimos a la paciente no llevarla a cirugía y llevarla a una arteriografía para evaluar realmente cómo estaba esa lesión. Les voy a mostrar la arteriografía.
Perfecto, gracias. So yeah, very interesting and a key point that Dr. Serna is making also for all the young surgeons in the audience as well. Very importantly, to involve your patients in the decision-making of this case, because as mentioned, you have this hemodynamically, neurologically intact patient, and you're talking about significant risks with surgery and with the operative approach. So patient feedback and input should be very important in the decision-making. Let's hear what happened next. Dr. Serna?
Okay. La paciente la llevamos a hacerle una arteriografía en donde tenía una oclusión completa de la arteria carótida común, como vemos en la imagen. pero se ve bien perfundido el resto del cerebro, posiblemente por la circulación colateral o por la carótida del otro lado. La siguiente pregunta es, después de ver esta imagen de la arteriografía, donde se ve una oclusión completa de la carótida, o sea, hay un trombo proximal y un trombo distal, la paciente no está sangrando, el hematoma, como decía ahorita el doctor Fernández, no era un hematoma expansivo, sino un hematoma estable. ¿Cuál creen ustedes que sea lo mejor para hacer con este paciente? Ya le hicimos una arteriografía donde vemos que está ocluida la carótida completamente, que tiene una buena circulación colateral y que su cerebro está bien perfundido. Quisiera que discutiéramos un poco en este punto. ¿Siguen pensando que lo mejor es operarla y revascularizarla? ¿Piensan que de pronto darle manejo conservador es una buena opción? ¿O piensan que intentar avanzar una guía a través del trombo y poner un stent sería una opción?
Interesting. So the patient is like, surgery, I'm not so crazy about that. So you want to take the patient to angiography, and the image you saw previously, and you see this image of a slight disruption, but there's definitely backflow through your circle of Willis. So now, seeing the angiography that Dr. Serna shared with us, would that change your approach? Would that change your earlier opinion about how to approach this patient? Would you still have a surgical approach, conservative endovascular? What would we do now? Let's maybe start with Dr. Rizoli. What do you suggest?
That's really a challenging one, right? Because this patient has the brain perfused and has a complete occlusion on one side. So I tell you, I would be talking to my interventional radiologist. I would be talking to vascular. I would be talking to neurosurgery, how to manage this patient. My initial thoughts would be, I would not try to stent through a completely occluded carotid. I think that during this procedure, you could cause microemboli or even big embolus to be actually loosened and then end up causing a stroke on this patient. So I don't think that an endovascular approach to a completely obstructed carotid would be an option. But I would be discussing with the vascular surgeons or the neurosurgeons whether we should do surgery for this patient or just leave it alone. But my inclination would still be to go and do surgery on this patient and do a bypass.
Excellent, thank you. Dr. Demetriades,
I agree with Dr. Rizoli. The anatomical location of the injury, it's very easy, straightforward. You can do it with closed eyes. It's not a complex procedure. The conservative management, I think it's not an option. There is a risk of clot progression or throwing emboli. Endovascular techniques, again, I think the risks outweigh the potential benefits. I would consider this option only if the injury is surgically inaccessible, very high in the internal carotid. But for this case, I will go in for open approach and revascularization.
Excellent. Dr. Santin.
Since in this hospital that I work today, I have endovasculars, I should perform that. But I think maybe embolized the carotid. So I think the best option is open, because a very difficult and hard case to discuss, because it's so challenging. I think might discuss with the vascular surgeon too. I think the best option here is still the open approach.
Excellent, thank you. And Dr. Gomez?
I won't change my mind. My approach will be surgery. I have a penetrating injury, very thrombosed carotid artery, very soon after the injury, in 1 hour, is completely shut down. And also for the surgery, the most important thing is to have backflow. And having this angiography, I have the security that during the surgery, I will have backflow. I can work very easy and with no pressure, with no stress, because I have a backflow. So I can make a very nice repair directly, resection suture, or I can use a piece of saphenous vein or a PTFE graft. I have
Just Tanya, sorry.
Yes, Dr. Demetriades.
Our plot in penetrating trauma thrombosis is equals transaction. It's not just an external. It's very rarely that we might have thrombosis without the transaction. It's in 95% plus cases, there is a significant transaction of the vessel.
Right. And do you agree? Would you use vein, PTFE? How would you repair this?
I feel very comfortable with PTFE. Especially, I do not want in the middle of the night to spend time harvesting the vein, especially if the patient has a difficult anatomical characteristic, is overweight. So I'll go straight for a PTFE, probably size 6 for this carotid, sometimes 8, but usually 6 is okay.
Excellent. Thank you. And Dr. Hernandez, ¿qué opina usted? Do you agree surgical approach, vein? And then we'll wrap up after this.
Con base a esta arteriografía, sí le daría manejo no operatorio inicialmente, verificar si cuento con el equipo necesario para poderle otorgar el beneficio, como bien comentan ustedes, y la seguridad a esta paciente. Teniendo el equipo y teniendo el personal médico adecuado, pudiera ser que de inicio el manejo no operatorio estarla en vigilancia y posteriormente ofrecerle tal vez el tratamiento endovascular. Sin embargo, también hay que tener en cuenta que esta cirugía, los cirujanos tampoco tienen la experiencia para abordar cuello. Entonces yo creo que cualquiera de las 2 o 3 opciones puede ser buena, pero teniendo en cuenta la capacidad de los recursos. Yo en lo particular sí le daría manejo no operatorio y posteriormente verificar. Si no tengo para endovascular, estoy de acuerdo con el maestro de Dimitri de ponerle un injerto.
So Dr. Demetriades, Dr. Hernandez was just mentioning that you make a very good point, Dr. Hernandez, that also it really depends on your local resources. That's like human resources, surgical resources, as well as material resources, because it sounds like you're mentioning that in Mexico where you're practicing, not a lot of people have seen this injury necessarily, or, you know, the surgical approach to this is not very common where you're practicing, where he's practicing. And so he was mentioning that maybe an initial conservative approach to this, perhaps endovascular, you know, later on, you know, despite that risk of embolic phenomenon. But I think it's a very good point that sometimes we need to do what we can with our local resources, what happens to be available. But he agrees that probably all 3 options are okay. But for him, it might be a bit different given local expertise, to be honest. And we'll pass to let's move along to the 3rd and final question, and we'll wrap up with this case.
Yo tengo esta tercera pregunta que íbamos a hablar de la antiagregación o la anticoagulación.
I want to emphasize here in antiplatelets and anticoagulation is good for blunt trauma. Mm-hmm. In penetrating trauma, it's not a good idea. You are going to open up and have a catastrophic bleeding, especially at the acute stage. Maybe later on down the road, many days later, you do a follow-up CT angio or ultrasound and there's no false aneurysm, there's nothing else. You might consider giving antiplatelets, aspirin, Plavix. But the acute stage, I don't think that is a good idea.
And Dr. Demetriades, would you therapeutically anticoagulate intraoperatively? Would you use only local heparin?
I use local heparin. I get 5,000 units of heparin. I mix with 100 ml of saline, and I flush proximally and distally.
Excellent. And then in the immediate postoperative period, do you leave the patient on a heparin infusion or nothing, or aspirin and heparin, or just aspirin? What do you do immediately postoperatively?
Aspirin is for 3 months. I had a case like that last night, actually. Aspirin for 3 months. If it's a very high-risk patient, maybe I would give him heparin for a few days. But in the vast majority of cases, I'll go for antiplatelets.
Excellent, excellent. And let's ask also, and Dr. Santin, what would you do for anticoagulation It looks like the majority of the surgeons would probably opt for a surgical approach to this versus conservative. But when you approach this and you repair it surgically, what is your routine in the operating room? How do you anticoagulate these patients at all? What do you tend to do post-operatively and perioperatively?
I think the best option is using aspirin, and I will not use in this moment heparin or other anticoagulant.
What about intraoperatively?
Heparin in the surgery.
Okay, excellent. Dr. Rizoli, any evidence guiding us one way or the other? Putting you on the spot a little.
Yeah, I'll just reverberate what Dr. Demetriades said. It's intraoperative, the flush with heparin, yes. And for most particularly blunt injuries, blunt cerebrovascular injuries, aspirin has been the choice, even though we still, I don't know, my impression is that I read on the books that mostly it's heparin that's used. At least in my practice, I see aspirin much more common being used.
Absolutely. Doctor Gómez, ¿qué opina usted? ¿Está de acuerdo o qué haría usted?
Completely agree. I don't want to talk about that because I will use heparin during surgery and aspirin after surgery.
Dr. Hernández?
Igual, de la misma forma, estoy de acuerdo con lo que comentan todos. Sin embargo, a lo mejor a mí me quedaría un poquito incierto el uso de la enoxaparina ya para tratamiento ambulatorio en los siguientes meses en mi hospital o en algunos centros, sobre todo los cirujanos vasculares lo emplean la enoxaparina o inclusive actualmente el rivaroxaban, que son heparinas de bajo peso molecular. Sin embargo, yo también optaría por dejarle la aspirina, como bien comentan todos.
Y doctor Hernández, ¿lo utilizarían los cirujanos vasculares como profilaxis, como terapéuticamente, o cómo utilizarían la heparina de bajo peso molecular?
La heparina de bajo peso molecular se la dejan, el rivaroxaban específicamente, que es vía oral, se lo dejan aproximadamente por 2 o 3 meses. Con controles radiológicos tal vez, no conozco bien el protocolo de ellos, ya que a veces llegamos a diferir los cirujanos de trauma con ellos en algunos aspectos específicos, pero sí, comentando algunos casos con ellos, utilizan el rivaroxaban como tratamiento ambulatorio, dependiendo del tipo de la lesión que hayan tenido. ¿Qué es lo que han comentado ellos en algunos casos que hemos manejado integralmente ellos y nosotros? Sin embargo, vuelvo a repetir, yo apoyo también el uso de la aspirina.
Excellent. So personal use of aspirin, but he knows that vascular surgeons actually at his hospital might be using low molecular weight heparin, but also some of the novel oral anticoagulants, even for up to 3 months postoperatively, and in the postoperative period. Very good. Dr. Serna?
Voy a terminar la conclusión de este caso. Fue a la paciente, decidimos darle manejo conservador. Así el análisis que hicimos fue que estaba ocluida completamente la arteria carótida, que no tenía ningún tipo de flujo. Por esa arteria le dimos manejo conservador, le dimos egreso de la institución, manejo con antiagregación durante 3 meses, la evaluamos a los 3, a los 6 meses y al año, y la paciente, eso fue hace más o menos 1 año y medio, y en la actualidad está sin ningún tipo de alteración neurológica y con su vida completamente normal, y no la llevamos a cirugía. Yo quiero hacer un comentario final, y es que en los últimos años el manejo de trauma de carótida penetrante, porque los casos que hemos hablado acá son de trauma penetrante, ha ido siendo cada vez más hacia el manejo conservador o hacia el manejo endovascular. Yo entiendo lo que comenta el doctor Demetriades y todos, que la carótida común es una arteria de muy fácil acceso. Sin embargo, nosotros hemos empezado a pensar en otras cosas que no pensábamos antes, en la cicatriz que queda, en los riesgos que tiene el paciente en el intraoperatorio, y cada vez más hemos ido dando manejo conservador. Esto era una oclusión completa y por eso decidimos darle manejo conservador sin ninguna cirugía, porque creemos que es diferente un paciente que tiene una oclusión completa a los pacientes que tienen oclusiones parciales de la arteria carótida y que tienen algún tipo de flujo, y estos pacientes tienen posiblemente un riesgo mayor de hacer embolizaciones cerebrales. Nosotros a todos los pacientes les damos heparina en el intraoperatorio y a todos los dejamos antiagregados por 3 meses. Pero digamos que la conclusión grande de este caso es que el manejo conservador y el manejo endovascular sí es una opción en la actualidad. De hecho, nosotros en los últimos 2 años hemos atendido cerca de 21, creo que 22 pacientes con trauma de carótida, de los cuales solamente 1 fue trauma cerrado y los otros 20 fueron trauma penetrante, y de esos a 17 pacientes se les hizo manejo endovascular, a 4 manejo conservador y solo se operaron 1 o 2 pacientes. Entonces, esto es para mostrar que en la actualidad el manejo conservador o el manejo endovascular puede ser una herramienta o una alternativa a medida que se van perfeccionando las estrategias para hacer la terapia endovascular y para pues mejorar los desenlaces con estos pacientes.
And so, Dr. Demetriades, and for the panelists, it's just very interesting because Dr. Serna was saying actually what happened with this case, to wrap up, is they managed this patient in a non-operative fashion, in a conservative fashion. They managed this patient in a non-operative fashion, in a conservative fashion, with conservative management, and basically put the patient on antiplatelet therapy, and has been washing the patient now and seeing them every so often now for around 1.5 years. And the patient has done very well so far, actually. And so Dr. Serna and Dr. Ordóñez, we'll hear from him in a couple of seconds, wanted to make the point that it's also interesting. They have a increasing case series of patients that have trauma to the neck, even including penetrating trauma to the carotid artery, even in zone 2, where it's surgically accessible, that they've actually been able to manage endovascularly. They've actually even been able to manage conservatively, with the key part being also when you have a complete occlusion, that's one thing, versus a partial transection or, you know, you're bleeding. So it will be very interesting to read about these case reports that are coming out. And then, of course, as Dr. Serna said, in the operating room, what they would normally do is this similar heparin and anticoagulation that other colleagues have commented on. Doctor Ordóñez, ¿qué opina usted?
Tania, gracias. Es que quisiera comentarle a toda la gente que nosotros hemos hecho toda la vida lo que dice el doctor Demetriades, de operarlos, y más si es la carótida común. Y comenzamos a hacer el manejo endovascular y conservador en la carótida interna, y ahora nos hemos extendido a la carótida común en trauma penetrante. Por eso era este caso en el cual decidimos hacerle el angio, y al ver que estaba totalmente trombosada, la decisión fue no operarla, ni siquiera hacerle manejo endovascular. Entonces, lo que queríamos comentar era que hemos ido pasando del operarlos a todos, hacer manejo endovascular a muchos y aún manejo conservador a otros. Entonces es como lo que queríamos mostrar y hacer como cuestionar al mundo que el manejo de la carótida en trauma penetrante puede cambiar igual que en el trauma contuso. Eso es, entonces no es que no estemos de acuerdo, sino que hemos ido evolucionando y creemos que eso es una posibilidad.
It is interesting how the paradigm is shifting somewhat, as Dr. Ordóñez was saying, at least with their local experience. And, you know, of course, they still can approach these surgically, but they are evolving, as he says, to be more comfortable and to use some more endovascular approaches, as Dr. Serna was saying also, but also to use more conservative management, even when we're dealing with the common carotid artery, even when we're dealing with penetrating trauma. So it's actually, and the angio is a good tool to see, you know, is it a complete occlusion or not, or how are we going to approach these patients? You know, even in this case, for example, if you're concerned about any hard signs like an expanding hematoma or whatnot, but their practice locally in Cali is indeed evolving clinically to be more welcoming of conservative management, as well as using endovascular approaches to these easily accessible lesions in zone 2. So that's an interesting shift from trauma surgery. Dr. Demetriades, what do you think? And then we'll ask the panelists some final comments.
Yeah, for at the acute stage, when the patient presents in an emergency situation within hours, non-operative management in penetrating trauma is extremely controversial. It might be something good, something interesting. You can put it together. You need to follow up these patients with vascular studies to make sure that there is no aneurysm, that there is no significant stenosis. And if indeed it works, then you should publish it. But without follow-up, maybe the patient has a stenosis and down the road to develop a stroke. Maybe the patient develop a false aneurysm, which is not an uncommon thing in penetrating trauma. I wanted to know if there is long-term follow-up with vascular studies in these cases.
Thank you. I will ask right now. Y doctor Ordóñez y doctor Serna, y hay casos, ¿cómo se siguen esos pacientes que se manejan de una forma conservadora? Por ejemplo, ustedes le ven en la clínica cada mes, cada 3 meses, ¿qué tipo de imágenes o investigaciones que se hace con esos pacientes? ¿Cuál es el manejo a largo plazo de estos pacientes con manejo conservador?
Bueno, nosotros los dejamos, como les dije, los que les damos manejo conservador, generalmente son los pacientes que tienen ocluida, como esta paciente, ocluida completamente la arteria carótida. Pacientes que tienen oclusión completa, que son los que les damos manejo conservador, los dejamos antiagregados durante 3 meses. Nosotros después del alta los evaluamos a los 8 o 10 días por la consulta externa y luego los vemos cada mes hasta el 3er mes. Generalmente, si el paciente está completamente asintomático, no le hacemos ninguna imagen nueva de control, y si es del caso, a los 6 meses o al año le repetimos una imagen para mirar cómo está estructuralmente la carótida de ese lado y cómo está pues el cerebro, que asumimos que está bien porque el paciente no tiene ninguna alteración neurológica, pero para mirar pues las carótidas y esto, ¿no?
¿Qué tipo de imágenes hacen ustedes cuando están siguiendo los pacientes a largo plazo? Como tomografía,
angiotomografía.
Angiotomography. Okay. So Dr. Demetriades, what we're saying initially is, so what they'll do is they'll see the patients very with short-term follow-up that's very rapid, like days to weeks, and then, every 3 months, every 6 months, that type of thing. But initially, actually, they will follow these patients based on their neurologic symptoms and signs, and any concerns obviously will, come back to the emergency department. But basically, what they'll do is they'll do repeat CT angiographies every 3 months or every 6 months, that type of thing, and follow these patients as an outpatient for now. Any comments on that, Dr. Demetriades? And we'll go around to the final panelists for, I think, final words to wrap up.
I think this is a very interesting approach. Non-operative management for minor penetrating injuries to extremity arteries has been described. And it can be applied liberally, and the rationale is, if something happens, it's not a disaster, you can fix it. But we have been very reluctant doing this non-operative approach in carotid injuries. Maybe we are wrong. Maybe our colleagues in Colombia can put these cases together and do follow-up CT scan, CT angios or color flow Doppler studies and publish maybe something new. But at this moment, at least in the States, is considered a no-no. If something goes all right, that's fantastic. If something goes wrong and the patient develops a stroke or hemorrhage or whatever, then you are in trouble.
Dr. Rizoli, what do you think?
Again, I agree. Once again, I completely agree, Dr. Demetriades. I find that one fascinating thing in blunt vascular trauma is that how grades can change as you repeat image. So often we repeat image 7 days later, and that's interesting. What may be a grade 2 all of a sudden is a grade 4, right? Or vice versa, or has completely healed. But even for blunt vascular trauma of the neck, if you have a grade 5, if you have a transection of the vessel for a blunt injury, the indication is surgery. right? Unless it's somewhere inaccessible, and then you may try on those rare occasions to get something endovascular. So once again, fantastic. It's something novel to me too, and I'm glad to hear. And I'm sure that Dr. Ordonez and his teams have been innovating a lot recently, and that this may be another area that may change. But for now, in my view, transection of the carotid, grade 5 injuries, be it blunt or penetrating, still most cases are managed operatively.
Doctor Hernández, ¿algunos comentarios finales?
Pues obviamente que el manejo operatorio y no operatorio, ya sea penetrante o contuso, pues bueno, siempre va a ser una controversia, y nuevamente pues buscar el manejo endovascular. Asimismo, para finalizar, pues bueno, es para mí todo un honor compartir el foro virtual con todos ustedes, y pues bueno, espero volvernos a ver próximamente en este tipo de foros o webinars. Muchísimas gracias a todos.
Thank you very much. Muchísimas gracias. Y Dr. Santin, ¿algunos comentarios final?
Was a very interesting case. Thank you to expose this case and the discussion. I think maybe Dr. Nuñez could publish the paper and everything to change, always innovating in trauma surgery. But I agree with Dr. Demetriades and Dr. Rizoli about lesions grade 5 that we need to go to the operating room and perform the surgery. I think we need to, this case is very challenging. It's uncommon, and we don't have a lot of surgeons trained to perform the surgery and everything. And we have in a lot of countries different options that maybe endovascular should never be possible, because they don't have this kind of treatment. So I would like to thank you to invited me to this panel. Thank you.
¿Y el doctor Gómez, algunos comentarios?
Yes, I think this is the wonderful opportunity that the Pan American Trauma Society is giving us to get connected with different point of view, and this topic give us the view that everything is still having a different way to manage, way to treat, and neck injury is one of these area that we will talk a lot about that in the future, with new ways to treat, to handle, and to understand the cinematic of trauma. And this is something very great that we can see in this panel. Thank you.
Excellent, thank you. Dr. Demetriades, any final comments or words?
Yeah, I found these cases absolutely fascinating, very educational, very thought-provoking cases. And I think the key message is that we need to individualize, depending very much on the resources each country and each place has, depending on the experience, depending on the individual patient. And there are many ways to approach an issue, a problem. And there's not a single correct way. So I think today it was a beautiful demonstration, fantastic cases. And again, thank you very much for making me part of this nice panel. Thank you.
Thank you. Dr. Rizoli, as the past president of the Pan American Trauma Society, any final very short, quick comments?
I'll just say that it has been an honor to be part of this discussion, and my suggestion to Dr. Ordonez is that he should write these cases and submit to the Pan American Journal of Trauma, not to the Journal of Trauma. And actually, I'll extend the invitation to all of you and all people who are going to watch this to consider submitting your work to the Pan Am Journal of Trauma. We really need your work and we need your support. Once again, Tanya, superb work. Thank you very much for the privilege to be here.
Dr. Serna, gracias por casos increíbles.